A nurse is standing in a corridor. In one room behind her, a patient is frightened, confused, asking for someone to stay. In the other room, a screen is waiting for her data. She has 60 seconds before the system flags her as non-compliant. She chooses the screen. Not because she doesn't care, because the system has made the screen more urgent than the person. I've been studying this pattern for 18 years, across 6 countries, across hundreds of conversations with the people running care systems. And the pattern is always the same. The nurse chose the screen because someone built a system that gave her no other option. This episode is about that system, its name, its cost, and what comes after it. Software as a service. 4 words. $1 trillion industry. And a lie hidden in the name. When you hire a cleaning service, they clean. When you hire a legal service, they handle the legal work. When you buy software as a service, they give you software. Then you do the work. The technology industry has been selling care organizations a tool and calling it a service for 20 years or more. And the care industry has been buying it, deploying it, training its staff on it, building workflows around it, and then wondering why the crisis keeps getting worse. The crisis keeps getting worse because the tool was never the solution. It was another demand on already depleted people. This year, Jefferson Health, one of the largest integrated health systems in the United States, announced an initiative with a single stated goal to reclaim 10 million clinician hours. 10 million hours. I want you to sit with that number because it doesn't just tell you something is wrong. It tells you where the hours went. Those hours exist right now, today. They are being consumed not by patient care, not by clinical work, not by the things these professionals trained for years to do, but by something else entirely. And a major health system has finally put a number on it. A Google Cloud commissioned Harris Poll survey, published in March 2026, found that clinicians spend nearly 28 hours per week on administrative duties. For medical office staff, it's 34 hours. 28 hours out of a 40-hour week, more than half. These are not outliers. These are not anecdotes. These are the median hours of a surveyed profession. In 2023, a peer-reviewed study was published in BMC Geriatrics. Not a survey, not an estimate. A study of 2,207 care workers across 118 facilities. Not 7%, not 17%. 73.9% of care workers are strongly burdened by administrative tasks. 3 in 4 caregivers arriving at work, knowing that the work waiting for them is not care. Workers with high administrative burden are 24% more likely to leave the profession entirely. The burden is not just consuming time. It is selecting against the people who care most about caring. The American Hospital Association released its cost of caring report this March. US hospitals spent $43 billion in 2025 trying to collect payments from insurers for care already delivered. $43 billion not spent on care, spent on arguing with insurers about care that was already delivered. When you add that documentation burden, the prior authorization workflows, the claims management, the compliance reporting, you arrive at a system that is spending more and more of its capacity on the administration of care and less on care itself. Now I want to show you what this costs when you zoom out. In Germany, 2 care facilities file for insolvency every day, not every week, every day. In the United Kingdom, 508 care homes closed in a single year. In the United States, 774 nursing facilities closed between February of 2020 and July of 2024. Germany, the United Kingdom, the United States. 3 healthcare architectures with nothing structurally in common. 3 different payer systems. 3 different regulatory frameworks. 3 different histories. The same direction of collapse. When 3 unconnected systems produce identical outcomes, you are not looking at 3 separate failures. You're looking at one structural force expressing itself through different local context. The World Health Organization projects a shortfall of 11 million health workers by 2030. 11 million. You cannot hire your way out of 11 million. There are no 11 million people waiting in a queue. But those hours exist. They are trapped. Trapped in a documentation system, trapped in compliance workflows, trapped in interfaces that demand the caregiver's attention and return nothing clinical in exchange. This is not a hiring problem. It is an architecture problem. The care industry has been told for 20 years that answer is better software, a better EHR, a more intuitive interface, a smarter dashboard, more training on the platform. 2 German insolvencies a day later, 518 UK closures later, 774 American facility closures later. The better software did not save them. The architecture failed them. A different architecture is possible. The alternative is not better software. The alternative is no software. Not in the hands of the caregiver. There is a model where technology delivers the work instead of giving you a tool to do the work. When you hire a cleaning service, they clean. Work as services, not software as a service. Work as services. Technology that operates in the background, that does the administration so the caregiver doesn't have to, that returns the hours to the people who should never have lost them. The best screen is a dark screen. The full transcript of this episode, the citations, and the care manifesto are available at anandchaturvedi.com. I am Anand Chaturvedi. This is Defending Care.